am a neuropsychologist at Lurie Children's Hospital, and today I'm going to talk about quality of life in pediatric epilepsy. Oh, thank you. From the time of diagnosis to surgical intervention and beyond. I have no disclosures. So today I'm going to talk about factors that contribute to quality of life in pediatric epilepsy, the nuances in quality of life based on different interventions, and then ways to support patients with epilepsy and their families. So quality of life is a subjective sense of well-being. So this can include, this is based on a child's their own values, their cultural identity, and circumstances that are unique to that individual. Measurement of quality of life includes ratings around a person's physical, emotional, and social functioning. And epidemiological studies show us that individuals with epilepsy are at greater risk for having impact to the domains of quality of life. This may be secondary to specific epilepsy factors, such as seizure severity and frequency, anti-seizure medication side effects, social stigma, and comorbid disorders, which I'll talk about throughout this presentation. So there's well-documented literature regarding the negative impact of epilepsy on different aspects of functioning. So that includes behavior, attention, and impulsivity, as well as internalizing symptoms such as depression and anxiety, as well as learning. So it's helpful to have different perspectives, and caregiver insight may be only available for children with epilepsy, given that children with epilepsy may not be able to rate their own quality of life based on their age or developmental level. So quality of life is measured through different ways. So there are different domains that we look at, such as physical functioning, emotional functioning, social functioning, and school functioning. And quality of life measures may be disease specific. So there are specific quality of life measures that look at epilepsy-related factors. So that may include impact on sleep and fatigue throughout the day. This may include different internalizing symptoms specific to epilepsy, so fear of having seizures. This may also include impact to social functioning, so stigma of having the disease and impact on friendships, and then also impact of learning and memory and how that impacts school functioning. There we go. So there are specific epilepsy factors that have been repeatedly shown as impacting quality of life. So this includes epilepsy severity, number of seizures per year, earlier age of onset, longer duration of the disease, and then being on multiple anti-seizure medications. But even at the time of diagnosis, so after the first seizure, we see that there are changes based on, impact on quality of life even at that initial time point compared to the normative sample. So individuals with epilepsy, thinking of it as a syndrome rather than just the impact of seizures over time is important to consider. So even children who are recently diagnosed that have not yet been treated, parent ratings show that there are differences in quality of life with lower quality of life as well as the subdomains that compose it. And it's not so much the significant differences in age, gender, or insurance type that they found, but it's really the comorbidities that are found at that time point. So that may be psychological factors and diagnoses, that may be developmental and learning differences, that might be other health-related factors such as obesity, asthma, and other comorbidities that may be present. There were no differences that were found based on focal versus generalized epilepsy diagnosis. But they did see that in children who are Black or African American, those individuals had lower ratings of quality of life compared to their white counterparts. There's also decrements in quality of life over the first 6 months of diagnosis during that acute period of coping with the diagnosis. So we see that those who had lower quality of life at follow-up at 6 months compared to baseline were usually those that already had lower ratings of quality of life to begin with. There are increases in internalizing symptoms, so anxiety and depression, with anxiety being more predictive of overall quality of life. And changing anti-seizure medications was linked to higher problematic behaviors. And then at 6 months, mood symptoms were still dependent from seizure frequency at baseline. We see over time that this change, that there's an uncoupling that happens where mood symptoms are independent from seizure frequency. So this means that this is the acute period of coping with the new diagnosis and the seizure frequency. Cognitive abilities were not significantly associated with seizure frequency, but they were based on the side effects of the anti-seizure medications, and we specifically see impact to verbal functions. So it's also, as discussed earlier, neuropsychological factors are impacted because of epilepsy. So this includes impact on intellectual functioning, memory, executive functioning, adaptive behaviors, and other aspects of daily functioning. And this is also significantly related to quality of life. So when looking at the contributions of different neuropsychological factors, the things that emerged as most relevant were verbal memory and then also emotional and behavioral functioning. So those who had a low verbal memory performance were 2 times as likely to have lower quality of life ratings. And those who had emotional behavioral problems were rated to have 10 times as likely to have impact to quality of life. And those who had comorbid verbal memory and behavioral problems were 17 times as likely to have impact to quality of life. So relationships suggest that there's also an impact on general intellectual level and working memory. So working memory is that your ability to hold information in your mind and being able to complete certain tasks. So this makes sense that this impacts daily functioning, given that this involves being able to sequence different tasks to complete a more complex daily living tasks, being able to complete chores and learn different life skills. Also, different aspects of executive functioning impact different aspects of quality of life. So for example, flexibility of thinking or your ability to shift from one task to another impacts your general emotional functioning. And also the ability to regulate your emotions and behaviors impact your ability to also complete adaptive skills or daily life skills. So it's important to consider the impact of socio-demographic factors on quality of life. So individuals who are of lower SES, who are in more or lower neighborhood, have higher neighborhood disadvantage, are 4 times as likely to have low quality of life. They're 6 times as likely to have a parent with a psychiatric history, 4 times as likely to live with a family receiving medicated, and are more likely to have more frequent seizures. So it's also important to consider the long-term impact of anti-seizure medications. But really, when we look at the association between anti-seizure medication usage from at 2 years versus 10 years, although we see an association, this is really driven by those premorbid factors. So really, it's the association was not significant after controlling for clinical characteristics such as seizure frequency, also family factors, and quality of life at 2 years, at the 2-year follow-up point. So meaning that those anti-seizure medications, those initial side effects that are seen at that 2-year mark are likely going to be more stable and going to be indicative of quality of life longer term based on those medications. Of course, if there are changes after that point, it's important to consider the risks and benefits of the medication on quality of life if there are significant side effects. So how about surgical intervention versus medications? So we see that in comparing the 2 groups, long-term follow-up shows that there may be similar rates of seizure freedom, but in the surgical group, we see that there is the seizure freedom is achieved sooner, and the children are on less anti-seizure medications at follow-up. Similarly, quality of life ratings differed with regard to seizure worry and medication effects. So there's overall improvements in quality of life when there is seizure freedom. But it's important to also consider the impact of internalizing symptoms. So we see a mediated relationship where seizure freedom results in improved emotional functioning, which in turn results in better function or ratings of quality of life. In this study, there was no differences found based on changes in intellectual functioning and quality of life. However, when we look at young adults who completed their own quality of life measures, who underwent pediatric epilepsy surgery, we do see a difference. And after accounting for mood, sex, and number of anti-seizure medications, the seizure-free group reported better cognitive and physical functioning and overall quality of life. And they also experienced less seizure worry and also had better self-perception. Consistent with the last study, mood was most consistently predictive in a covariate that independently explained different aspects of quality of life. There are a few studies that have actually looked at what we consider palliative options for epilepsy surgical intervention. So the couple of studies that have been published include an older study about corpus callosotomy that does show improvements in adaptive, family, and school functioning, as well as seizure reduction, which were all related with higher levels of life satisfaction overall. They did not find significant improvements in cognition that impacted quality of life. In a VNS study that looked at early VNS implantation, so at or younger than 5 years old versus late implantation, so over 5 years old, that there were similar rates of response to the VNS in terms of seizure frequency and reduction in anti-seizure medications. However, the group that was implanted early, so before 5 years old, that group had better quality of life scores, both with regard to general emotional and social functioning and also cognitive scores. So beyond the child, it's also important to consider the family unit. So in a sample of pediatric epilepsy patients, 42 presented with moderate or severe intellectual disability. Most of these individuals stay stable even after surgery. So there was still 36% of the sample that maintained similar deficits, so 80% of them. So it's important to understand that while there are still improvements in quality of life, at 2 years follow-up based on parent ratings because of the seizure freedom and the burden that has on an individual, there's still ongoing caregiver burden, given that these individuals still need lifelong supports. We also see a reliable relationship between maternal depressive symptoms and a child's quality of life ratings, with higher depressive symptoms rated by mother also indicating worse quality of life ratings for the child. The good news is there are factors that are modifiable. So we see that when a family has more resources, that actually moderates the relationship such that children are able to have better quality of life ratings even if there are maternal depressive symptoms. It's also important to consider that family resources also moderate the relationship between quality of life and seizure control. So again, such that seizure freedom and quality of life ratings, so seizure freedom and higher quality of life ratings is moderated by being able to those family resources. So those with higher resources were rated as having better quality of life than those with lower resources. So in summary, I think it's important to consider the complex interaction of quality of life through an ecological model. So at the individual level, a child's quality of life is dependent on individual factors. So that includes epilepsy factors such as seizure frequency, anti-seizure regimen, There's also the microsystem, so that includes the family factors, parental education, as well as family psychiatric history, educational level, and then the exosystem. So what is that? That's those modifiable factors that we can contribute to as well. So environmental factors, neighborhood disadvantage. So how do we help support families so that we can improve the quality of life in individuals with epilepsy? So I think it's important to screen for risk factors at the onset and throughout the course of epilepsy to identify those risk factors that may impact a child's quality of life. And then also I think it's important to work as a multidisciplinary team so that we think about a child holistically. So this includes psychoeducation in a child's preferred or the family's preferred language and modifying the information to their specific learning style. Supporting access to medical care. So many children, as we just discussed, many children live far from epilepsy centers. And so how do we support those families to, in terms of like transportation or childcare if they have multiple children that they're caring for so that they can make medical appointments and get the interventions that they need. Also linking families to community resources when those risk factors are identified. So that includes mental health resources, services, and therapies. So identifying those factors that are related to cognitive and emotional functioning. And then also rehabilitation services based on ongoing deficits, and then community linkage to advocacy centers and also support groups. All right, thank you.